Hi, everyone. I'm truly honored to be here today. It's a pleasure. And I do want to give thanks to the Algonquin people whose land we're on today. And I'm going to break the mold a little. I don't have slides, and I'm not going to describe the problem to you. I hope I'm going to describe part of a solution to you, and that is I did anticipate that the majority of people here would be more community-based and less health-based. And so I want to talk to you about public health as a partner and what public health can bring to you in doing this work. I started my formal public health career in Toronto, working alongside individuals like Ron Labonte, Liz Jansen, Trevor Hancock, Betty Bircher, Jack Layton, names that will mean something to many of you in the room. And fairness, mitigating marginalization, advocating for policy well beyond the authority that we had, and doing much of our work in partnership with community groups, lay people, government departments, and healthcare was what public health was all about. It's what it meant. My informal start in public health started much earlier. As a child growing up with a nurse mom who worked in community and school health and who had a very high alignment between her very active volunteer social change life and her paid work life. And my introduction to primary care and the actual clinical side of a kind of work that relates to determinants of health started when my pediatrician opened a free inner-city clinic when I was still in high school and invited me to be his weekly volunteer for everything non-clinical. My learning curve was steep and sweet. And today I work at a National Knowledge Center for Public Health to public health strengthen its ability to do exactly this. And I do know, before I start, that not everyone in public health prioritizes upstream work, nor does everyone put health equity advancement at the heart of public health work, although they should. A 2012 study in Canada found of public health interventions that only about 25% of public health interventions addressed health equity, and of those, only 16% addressed structural changes. So as a field, public health still defaults to programmatic interventions, and using terminology from Nancy Edwards, who's here today, is often found tinkering at the edges of structural disadvantage. So even though we see, where I sit, continuing risk for public health leaders who champion health equity, and we see setbacks, sometimes big setbacks, like Quebec's recent narrowing of public health scope and roles, at the same time, we see a huge growth in some people in all jurisdictions, all across Canada, in all disciplines, from provincial public health leaders, there's at least one here today, to frontline staff, actively engaged in actions that will shift health equity. And so I want to talk about that possibility to you from the perspective of our center, because the users of our center are stellar partners for community. And as they join with you, as public health often has in the past and can be encouraged to do in more jurisdictions, you will find that the change that you can leverage, I think and hope, could be increased. So we did an appreciative inquiry from our center a couple of years back, and we wanted to identify factors and conditions that influence the effective public health leadership to address social determinants of health and health equity. And what we found was that there were three key supporting factors. First, but in no particular order, was professional competence. No surprise here. The leaders have to have essential knowledge, they have to have skill, they have to have the right kind of attitudes to do this kind of work, they have to believe in health equity work, they have to want to do it, and they have to have the savvy to do it well. Second, they need organizational supports. The institution where those public health leaders work must support this work, at least at a modest level, and ideally, the more the better. And so some of the equity leaders in public health work in institutions where this is at the heart of their commitment. It's named, it's explicit, it's in standards, and we have 3 provinces in Canada today that name this kind of work within provincial standards, and so then that makes it easier for regional and local people to be moving that work forward, and so we need every province to catch up there. And the organizational support allows leaders to leverage resources. Sometimes that's money, just a little bit can turn a corner. Sometimes that's people's expertise and time, a community worker, an environmental health officer, a nurse being assigned to work with community, expected to contribute, and charged to report back. But also systems and information. So a good example of that I'll talk about in a minute is population health data and analysis. And you've already seen in all of the earlier presentations, the importance of how data can be used to tell a story. Third, and especially critical for the health equity work, is that a good leader must bridge between the organizational activities and community action. They must be able to have a foot in both camps, and the best leaders can move with high respect, credibility, and trust between government, institutions, and community. They know how to partner and engage with community. They're skilled at asking and listening. They know how to speak with authority and humility, and they offer respect really widely. Claire Bechter, who's now a director at Manitoba Health and associate with our center, has been mining leadership literature to figure out how we can bring some of this into public health. And her research findings really stress the relational nature of leadership to advance equity. So leadership is granted by community, by peers, and by partners through relationships. Access to essential community knowledge, not research knowledge, but community knowledge, comes through established relationships. It also, I must say, research knowledge comes through those relationships equally importantly. And without strong and well-nurtured, multifaceted relationships, leaders are often adrift and their impact diminishes. So at our center, we recently convened folks involved with 5 cross-sectoral collaborations in different provinces working on issues of homelessness, early child development, youth health, anti-poverty, and changing settings that create tendencies towards obesity. Our interest was twofold. We wanted to learn about the experience of using collective impact models, particular model to work intersectorally and advance complex change, and we wanted to learn about public health's contributions to those collaborations. The community activists who were involved in this multi-site gathering echoed the dynamics I named. They did that same kind of list that we found in the literature and through an appreciative inquiry. And they really stressed public health's contribution of bringing credibility so that often a coalition's message can be better heard or received. And in part, that's because of the social privilege conferred fairly automatically to doctors and professionals, but also in part because of public health's long-established track record of staying the course in social change efforts that are slow and incremental. And also because public health has successfully been at the heart of collaborative efforts to create positive social change in the past. And it's really part of the early history of public health that for some public health jurisdictions was diminished in the last generation or so as we got caught up in disease treatment and antibiotics, but for many public health practitioners it never shrank. So I want to tease out a little bit the way that public health does help and can be asked by you to help. And I want to stress how important it is that as public health comes to you as a partner, that they're also trying to make change themselves, and this is not true for all jurisdictions, but certainly more and more, in modifying its own expectations and its own practices. So we have people in the room, I'm looking at Corey Nudoff, who's been a leader in this, who's been doing things like relocating clinical services, finding good evidence and evaluation informed ways to improve access to programs, engaging with Indigenous communities, learning to ask and listen of community members and clients about needs, influences, concerns, and also assets and strengths and how to build on those together. Tailoring services to be universal and targeted at the same time. And in spite of inherent risks, engaging in advocacy for social, economic, and environmental policies, not just health policy change. I think one of the interesting things in this work is that public health is improving its ability to talk about determinants and equity in ways that people will listen. And certainly Upstream is doing that work today superbly well. One of my public health colleagues who's really devoted some effort for that is Christine Johnson. She is the public health equity lead for the part of Nova Scotia where I live. And they're training staff in Nova Scotia to speak in lay language, to know enough about local and local situations of disparity, to use local examples that people will recognize. One of the issues in Nova Scotia today is about environmental racism, how Indigenous and Black communities in our province are, and all across Canada and the world, are disadvantaged through placement of dumps and industrial facilities. And so how can we speak to that both individually and with people? And speak in ways that will draw listeners and audiences and supporters across religious and political view. I live in Peter MacKay's old riding. It's a fairly Scottish, fairly Catholic community. It's It is both conservative and not conservative. It is one of the richest social change neighborhoods in Nova Scotia, in part because of the Coady Institute, and very radical nuns who've been there for 200 years. And so we have to speak across a multiplicity of worldviews in that community change. And rather than ignoring personal voice, part of what public health is trying to figure out how to do is ask good questions about that, because many of our community members have been taught and believe that personal choice and lifestyle is key to good health. So how do you ask about how the availability and accessibility of food and food stores influences people's access to fruits and vegetables, recognizing income? How do you ask about social factors that dissuade women from breastfeeding? How do you ask about the lack of public transportation contributing to social isolation and mental less well-being? How do you ask about the factors that contribute to inequitable patterns of income in our community? And so at our center, as we look at that with public health, I was thinking I would start with some sampling of public health stories from across the country, but instead, and I could look at public health's role in the Nunavut Food Security Coalition, Southern Vancouver Islands Child and Youth Network, some of the health in all practices that are changes that are happening, but I'm going to use the story of the Peterborough Public Health contributions to the Peterborough Poverty Reduction Network as a way to illustrate a story that's actually happening across the whole country. And public health is involved in poverty coalitions, food coalitions, housing, homelessness, mental health, school readiness, school graduation projects. You name a social policy issue, public health is probably there somewhere in the country. And for the Peterborough story, I want to give thanks to Christine Post. She's the health promoter in Peterborough, who for the last 9 years has had an assignment about poverty. And so the Peterborough Network was created in 2008. It grew out of a mayor's committee. It's an incorporated nonprofit organization that's independent. It's under the direction of a voluntary community board, and it brings together over 60 agencies and dozens of individuals. There are 6 issue-based work groups, a communications committee, and a steering group made up of the chairs. Public health is on 4 of those working groups. The local medical officer of health chairs the food security group. That puts her on the planning group. Public health has contributed to network development, community engagement, and consultation, planning, evaluation. They can put resource into preparing proposals for external funding. They've brought their human resources expertise to helping to recruit and hire staff without controlling the hiring committees, and they use their space to host meetings and events. They've brought their data collection, analysis, and reporting forward so that they can provide a very strong role in creating specific reports about local policy and interpreting data so that the board and the community members can use that data to design actions and recommendations. Another big role has been with municipal policy analysis. They've co-hosted a wide range of policy consultations, wrote letters, prepared reports, made presentation to council, so that they've influenced discretionary and emergency housing benefits, emergency dental treatment, municipal food programs. They're superbly positioned to bridge between the local and the provincial, even up to the national. So they've been able to help mobilize local voice to take voices into social assistance reform, minimum wage review, putting food in the budget campaigns, and a provincial campaign to shift oral treatment for poor Canadians. And it's no surprise that people reach out in terms of partnership, and so there they've been able to help with local community education, local partnership, and drawing upon in Peterborough, something that not all health units have, but should, a long-standing partnership and service agreements with the local First Nations community. Last year they just started a digital storytelling project to capture local voice. And finally, they've given a huge role in planning and evaluation, helping to design indicators, helping to train participants how to monitor impacts and success. So that's just one story, and I share it with you today so that you can demand the same from public health wherever you live. I know there are a lot of people from Toronto here, and I think most of the people from Toronto will consider Toronto a public health partner. That's not true everywhere, and I really encourage you to be the ones calling on them to move upstream and change determinants of health. Thank you.